Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. There is a lot of good news when it comes to cancer. Detection and treatments continue to improve. And the big picture, cancer is killing fewer Americans than it did 30 years ago. That, of course, is something we're celebrating. But today, we are focusing on perhaps the most concerning trend in cancer. More and more young adults are getting colorectal cancer, and we just don't know why. Take a look at these graphs here on your screen where the blue line represents colorectal cancer. The left graph is men, the right is women. The newest numbers from the American Cancer Society show that for people under the age of 50, colorectal cancer deaths have now surpassed lung cancer, making it the leading cause of cancer death in men under 50. In women under 50, it's second only to breast cancer. And just like any cancer, early detection is key. But what should people in their 20s, 30s, and 40s be watching for? And if someone does get diagnosed, what does treatment look like? Today, we are hearing from someone who has been there. Tiffany Kessler across from me is a colorectal cancer survivor. She was diagnosed at age 40. Glad to have you with us today, Tiffany. Back again on our program. Yes. We're also joined by her surgeon next to her, Dr. John Ashcraft, the Division Chief of Colon and Rectal Surgery at the University of Kansas Cancer Center and the health system, along with surgical oncologist Dr. Mazen Alkaspouls, the Director of Regional Cancer Therapies Program here at the health system. Welcome to all of you. Really important topic to talk about, and a lot of mysteries surrounding these numbers that we're seeing. So we're going to dive in. And Dr. Alkaspouls, you've gone as far as to say this is an epidemic when we're talking about the rise in patients. I know that's a term, a big term to use, but I think it really demonstrates your concern and your passion.
Yeah, I mean, it's not really an epidemic. It just feels that way in people who are in the field, because every time we have clinics, we're just seeing more young people with colorectal cancers. Actually, it's all cancers, but colorectal is the most striking. And, and you see people in their 20s, 30s, and early 40s. I mean, we never saw this. When I was in training, if someone had even rectal bleeding, if you even mentioned cancer, you were ridiculed. Like, that was never even part of something you thought about.
That was so far off.
Yeah, and now it's like, we pay attention to everything now in younger people.
You almost go straight to it, like it could possibly be.
I think they definitely need a colonoscopy. We can talk about that more, but certainly, yeah, we have to take everything seriously now. Dr.
Ashcraft, what are you noticing in your kind of the age demo of your patients?
The same thing. I was rounding this weekend, and our patient average, just for the inpatients, was 43 years old. That was unheard of years ago. I mean, when I started my practice, when Dr. Alkaspouls started his practice, we would see 70, 60-year-olds. That was kind of our average. But here I am rounding this weekend, and our average was 43 years old.
Yeah.
And so younger and younger and younger patients.
People that look like Tiffany, and you were saying this morning, you were like, this is not really, I don't look like somebody who would have that. Talk to us about that.
Yeah, so, we'll talk about it in a little bit, I think, but, I had kind of all of the symptoms that you would think are associated with, but in my mind, cancer was kind of very low on the list. It was kind of like maybe Crohn's, maybe diverticulitis with all these GI symptoms. But cancer was just not on my mind, I think, because I was female and young and not a smoker, vegetarian.
Yeah.
So
a busy mom, don't have time for cancer.
No.
And as you had mentioned, and Dr. Ashcraft, there's other things you might go to. There's so many other GI problems it could be, right?
Always. And Dr. Alkaspouls lead onto it. 9 times out of 10, the primary care doctor will say it's hemorrhoids. And that's very common. And especially in a young female, you would expect that, or a young male. If somebody walked into our clinic back when Dr. Alkaspouls and I started our practice and they said, oh, I've had some bleeding, it's bright red, it was always trumped up to hemorrhoids.
Yeah.
But we don't do that anymore. We've learned through patients like Tiffany is that, there's cancer showing up in younger and younger patients. Now, the odds are, and I want to put everybody calming, is that if you're bleeding, it's probably going to be something benign. But we just know that since cancers are rising in those 40 to 50-year-olds, that we should check into it. And so now, much like Dr. Alkaspouls said, when you walk into our clinics, you've got bleeding. I don't care if the hemorrhoid's staring at me waving. We're still going to do a colonoscopy.
Right. Do they wave? Did they get that big? Okay, good to know. So it sounds like these patients are kind of quote unquote too young to get a colonoscopy. So do you think that the age of 45 should be lowered? It was recently lowered, right?
It was.
How do we get it knocked down even further.
There were two things that I was hoping would come from the change that the American Cancer Society brought on, which was lowering the age of the scope. They went from 50 to 45. I wish they would have gone to 40, but they didn't quite go that far. And the other thing is we routinely will let patients go 10 years between colonoscopies. I was kind of hoping the 10-year colonoscopy would go away and we would go no longer than 5 to 7 years, because we're seeing so many patients that walk into our clinic that say, I had my colonoscopy 5 years ago and it was normal. But they not only show up with a cancer, but they show up with an advanced cancer. And so I was kind of hoping those two things would change. They didn't quite yet, but I think as time goes by and we learn from patients like Tiffany, that we'll be able to adjust better.
Is it quite a process, though, to get that lowered?
Oh, yeah.
I would imagine.
Oh, yeah.
I would imagine. What do you think's driving this trend? I want to ask you both. Dr. Alcaz-Pools, I'll start with you.
Yeah, I mean, it's difficult. I wish we knew for sure. I mean, I think we do know it's got to be environmental. It's not genetic. There's no way over a decade or two that genetics have changed so much that you see this kind of rise. So there is something environmental, there's no doubt, but we haven't pinpointed it. I mean, there are so many possibilities, weight gain and, smoking, although I think people are smoking less now. Obviously, there are the stuff in our food and what we drink, we talked about microplastics or nanoplastics now that are that they're finding in foods and even liquids in these plastic bottles. So I think it's a very microbiome. A lot of people talk about the microbiology of what's in your stool. Your colon now is different than it was, 20 years ago. So there's a big interplay. But I truly think there is something, that is there. That it's not. Although it's multifactorial, I think there is one factor that we have not discovered yet that's really causing all this. It's going to take a while, but I think there's something there.
But frustrating, because you come on this program and you've got all sorts of good answers, and then there's this one thing that's affecting your patients, and you just cannot put your finger on it. What do you make of it?
Same thing. We don't know. We don't know why patients like Tiffany are showing up younger and younger and younger. We talk about microbiome. We talk about environmental factors. We talk about processed foods, and our processed food intake is higher than our kids or than our parents, and our parents was higher than their parents. Is it something related to that? Is it the genetics, much like Dr. Alcaz-Pools says? They shouldn't have changed that rapidly in a couple of generations, and so I doubt that, but probably a combination, a multifactorial combination of kind of the perfect storm, but we don't know, and we need to figure it out, because if we don't, I'm worried we're just going to see more patients like Tiffany.
It'll get lower and lower in their age. Let's talk about the symptoms. The American Cancer Society came out with 5 signs of colorectal cancer that you should not ignore, even if you're a young adult. We're going to put these up on the screen, but a change in bowel habits, blood in the stool, abdominal pain or cramping, unexplained weight loss, fatigue. Dr. Ashcraft, which of these symptoms raises the biggest red flag for you? What might go, you talk about fatigue, weight loss, that could be a million things. So what should someone really be honing in on when it comes to this?
Not only those symptoms, but the combination of them. Okay. And we'll let Tiffany get into her story, but bleeding with a change in bowel habits that kind of persists, abdominal pain that just kind of continues and persists, and definitely weight loss for no reason. That's always a scary factor for us as oncologists. It worries us immensely.
And it's hard, because these are the topics that we don't always want to talk about. It's not an area of the body that's always comfortable to tell somebody, hey, this is happening with me. What should I go see a doctor? How do we kind of change that perception and make people more comfortable talking about it?
I think every point that's been made is excellent. I think the key is you have to be. I think younger people feel invincible, right? You just don't think that something like that can happen in you. You have to be very well in tune with your body, and that's the key. I mean, you just have to. These differences that Dr. Ashcraft mentioned, even these subtle changes, you have to be aware of and take them seriously. I was in that age too. I thought I was invincible. I never thought I would get cancer at that age, But the reality is, if I was that age now, I'd be worried.
You'd be all over it.
Yeah, exactly, because of what I've seen. It's scary. Yeah.
So how do we move the needle on being comfortable talking about it? I mean,
that's just it. Just be comfortable.
Doing what we're doing today.
Our primary care doctors need to be more comfortable having the conversations, interacting with the patient, direct conversations, and saying, hey, tell me anything that's going on. How are your bowel movements? Having any bleeding? Oh, you are? Well, let's discuss that further. Let's look into that more. Do you have a family history? All these things play into it, and we just need to be open to having those conversations.
So Tiffany, diagnosed at age 40?
Yes.
So what symptoms were you having?
I mean, I look at that checklist and I can check off every single one, but I think for me the problem was that it was over a period of time. After I had my third kid, I kind of had my digestion changed. I was very tired a lot, but I would talk to my friends, they're tired too, we've got young kids. And so, after these symptoms kind of persisted for a while, I went and talked to my primary care, and we did some allergy testing and some other things, and it would kind of help for a while, and kind of cyclically I would get better, and then my symptoms would kind of reappear for a while, and then those times of feeling good would be shorter, so I'd go back in, we'd kind of play around with some other things, do some lab work, and then it wasn't until maybe a year and a half of having these symptoms that the bleeding became more persistent, and that's when they kind of said, I think it's time to get a colonoscopy.
And how soon after you had your child were you noticing this? Because I could see where people, you're pregnant, your body's doing all sorts of weird things.
Sure.
So I would chalk that up too.
I would say maybe a year after I had him, and I was diagnosed when he was 4.
Did she do the right thing? Should she have seen you sooner? Was she doing the right thing, questioning it? And how does it all, what did she do right? Is there anything she could have done differently?
I think, if I remember right, you went to your primary care doctor and they knew about this happening, and there was a conversation about this potentially being hemorrhoids or something not as worrisome. I think now we've moved the needle with our primary care doctors that her description of her symptoms would be very worrisome, and we would push for that colonoscopy a lot sooner. The fact that Tiffany was willing to have those conversations with her primary care doctor, the fact that she was willing to advocate for herself and say, I'm having these problems, I'm having these issues, I think that's the biggest thing.
So that's what I want to know is if she, not here necessarily, but let's say she goes to a primary care physician elsewhere and maybe isn't listening to or seeing the signs that Tiffany is seeing. How does a patient push for that colonoscopy? How do you do it? What are the words we use?
I think you just have the conversation. I did it with my primary care doctor. I swore I wouldn't die from what I was going to treat, so I pushed. And so you just got to be willing to have that conversation and say, hey, I'm really kind of concerned about this. These really worry me. I really think this could warrant looking into it further. Would you think a colonoscopy would be okay? And I don't see many primary care doctors denying that.
Not pushing back.
Yeah. I think that's exactly it. If you tell your primary care doctor, listen, there's something different, I'm worried about cancer, I've heard about colonoscopies, I guarantee that primary care doctor will ask for a colonoscopy.
Even if you don't meet that criteria.
Yeah.
So you get the colonoscopy, you're going to think it's anything but cancer, but you hear it's cancer. What was that like for you?
Oh gosh. I think because it wasn't even, maybe if I think about it a little bit, it was on my radar a little bit, but my husband and I walked out of that colonoscopy, and I think it was just kind of like, I don't even think he used the word cancer. I think he said malignancy, and here's a referral for an oncologist. And so I think my husband and I left, and we were like, this is what we think it is, right?
Right?
This is cancer, right? And so I think we were kind of floored, and then it was kind of a whirlwind after that, because he was like, you need now, do this now, call today, and then we kind of got referrals, and I think 2 weeks, maybe right at 2 weeks after my colonoscopy, I had my first chemotherapy treatment.
And most people don't have an oncologist on speed dial, so I could imagine going, what did I just hear? You go through this major chemo regimen, then radiation, then surgery. What was that like for you? What was the worst part of it?
I think, honestly, in it, you're just kind of in survival mode, I think, and you're just like, these are the steps that I need to take to get rid of the cancer. And so I think I was very much in a mentality of, this is the next step, and Dr. Ashcraft and Dr. Al-Rajabi, who was my oncologist, were very good about, this is the plan, we have a plan, and just take one step at a time. And yes, it was difficult, and the treatment was rough, and there were moments that were very tough, but I think I knew that, you know, to be here for my kids and to get through it, it's what I needed to do.
What's it like sitting here next to her?
Oh, it's amazing hearing Tiffany's story. And I would just point out her statement of, you know, within seeing the colonoscopy and then coming to our cancer center and starting chemotherapy within 2 weeks. A huge shout out to our navigators, a huge shout out to the cancer center. They do an amazing job of helping patients see the system and get through the system, because like you said, we don't have an oncologist on speed dial. You don't have a surgical oncologist on speed dial. You don't have that, but our navigators do. And so that path really works well and helps greatly.
It's really overwhelming. And she had mentioned all these steps one by one, and you got somebody there to take you through one by one. What's the relationship and the communication like with two doctors like you and dealing with a patient and making sure that they get through those steps together, and how you guys are working in tandem?
So we do frequently. Dr. Huckespools gives a unique therapy here that is not offered anywhere else in this region through hypothermic chemotherapy for really advanced cancers, not Tiffany's situation, but for other cancers. But more importantly, she mentioned Dr. Al-Rajabi. Raed Al-Rajabi was her oncologist. We have clinic at the exact same time, right across the hall from each other. If we have questions, we can come right across the hall and say, Raed, you know, what's going on with Tiffany? I see her white count's down, or this is happening, or that's happening, and I got an alert about this. What are we going to do? And we constantly discussing patients. And equally as important is every week we have a tumor board, and that tumor board is multidisciplinary. We have every group there represented, and we discuss patients like Tiffany. We say, look, this is her tumor. This is what's unique about it. This is the standard approach, but should we use the standard cookie cutter approach, or should we hit her with something a little bit bigger? Which was kind of Tiffany's story. We kind of hit her. Raed used a pretty aggressive chemotherapy regimen on her, FOLFIRINOX, and so it was intense.
I like you painting that picture, because it really is that. Like, I love the idea of you walking, literally walking across the hall. It's not sending off some sort of image to someone to get lost in an email and look at later and get back a week later. You're really walking in and saying, hey, I need to know this right now, and getting everybody on board.
And Dr. Ashcraft made a good point. You know, these tumor conferences, almost like getting like 25 to 30 doctors for the price of one, because we're literally that many people that are sitting around discussing these things. You know, most people, it's usually a Zoom meeting, but still, there are literally like 100 participants. I mean, in these conferences. All
these eyes and all these really smart people. Tiffany, how does that feel to know that you have all these people with input?
It was very comforting. I think not only, like Dr. Ashcraft said, to know, because you know, when we met the first time, that we have tumor board later this week, we'll talk about your case and make sure that this is really, you know, the approach we want to take. And then, like he mentioned, in clinic, just when I would, you know, go in for appointments, and they would both be, a lot of times, they would both be in the same room at the same time. And it was just very comforting, like you said, to know that they were on the same page, and to know that I'm not getting one answer from one doctor and then asking the same question a few days later and getting a different answer. They were very much, you could tell, they had a great relationship and communicated well with one another, which as a patient is a huge blessing.
So those are important relationships here at the health system, but outside of the hospital, you got to go home and be supported by those around you, which is, I know these guys shaking their head are like, that's, you got to have somebody to catch the ball when they leave here every day. Who was there to support you?
Oh my gosh, so many people. I mean, I had my husband, my kids, and a whole, as you can see on the screen, a whole community full of people that just rallied around me and my family and loved my kids when I was kind of out of commission. And yeah, I'm gonna cry. I can't even watch it.
Well,
but,
if I can say, you cry because you said people there to kind of help you with your kids, because I think as a mom, the idea of like someone else, you just, you know, that's what you're living for right there.
And you know, that's brave. I mean, asking for help is sometimes the hardest thing to do. You know, we try to be self-sufficient, but you know, you got to let people help you. You know, that's one of the hardest things. She touched on something that's very important. The impact this has on younger people is a lot different than older patients, you know, because so many more people are involved. You know, her husband or her kids, you know, there's a financial impact, you know, there's the care for the children. I mean, just...
They're working.
Yeah, I mean, it's like a snowball effect on, you know, the people that are affected when young people get cancer with families, and that's usually the case, you know. And
very good point.
Yeah.
We have some questions. We're going to talk about family history here in just a moment. And if you're watching live and you have some questions, use the chat on YouTube or Facebook. You can tweet us or email the Medical News Network. Information is right there on your screen. We have a quick update on our COVID count this week. We have 18 inpatients, including 2 in the ICU as of Monday. Dr. Ashcraft, so walk us through Tiffany's surgery. What'd you do?
I don't know how much she wants to hear this. She's heard it. She's heard it before.
Okay, let us have it.
She's been there. So first, I want to specify Tiffany had rectal cancer. We say colorectal cancer a lot, but Tiffany had rectal cancer, kind of a special subset in that there's a lot of instances where we don't go straight to surgery, which was Tiffany's situation. She got chemotherapy and radiation first, shrink the tumor down, and then we took her to surgery. The reason why is because in the olden days, way before Dr. Alcaspuls and myself, if you took a patient to surgery, 1 in 3 would have the tumor come right back in the pelvis, a 33% recurrence rate. But when we treated patients like Tiffany in her way, that was only 3%. And so we did that so that we could get a better surgery out of her. We did a robotic approach on her. We went down, we removed her rectum, reconnected things. Because she'd had chemotherapy and radiation, I did have to torture her with a temporary ostomy or a temporary bag for a little while. She did great through that. And then we had a second surgery a little while later to make that bag go away, about 8 to 12 weeks later. So
then let's go back to that point, because what's the difference then between colon cancer? We use that word a lot. It's colon.
We do.
Is it the same? How much different is it than when we talk about that in rectal cancer?
It's really different in the way that we approach it and treat it. We know that rectal cancers have higher rates of death. They have higher rates of recurrence. And so because of that, we get a little bit more aggressive with those in terms of giving that chemotherapy, giving that radiation first, and then taking the surgery. Whereas with colon cancers, Dr. Al and myself would typically just take those out, straight to surgery, get them out. There are some instances now where we're looking at, and the research is showing, they may do better if we give them chemotherapy first. We rarely, if ever, I don't think I've ever used radiation on a colon cancer, but it's very common in rectal cancers. And so it's those nuances of difference. And again, going back to what Dr. Alcaspuls said, that's why the tumor board is so important. The radiation oncologist there, the radiologist there to help us look at the tumor and determine which stage is it. It was stage 3 when Tiffany presented, which means the lymph nodes were involved. And so giving that radiation and giving that chemotherapy helped clear that out and treat it so that we could get a much better surgery and get all that cancer out of there.
So cancer-free, no evidence of disease?
Yeah, no, and also, there are radiologists there and pathologists. We don't talk about this enough, but, they go through the films again. It's like they get another look at it, because sometimes things are picked up that were missed the first time. So the radiologists look at things again, the pathologists look at things again. That happens more often than you think.
We just talked a couple weeks ago about the importance of pathology, and every stage, every person looking at this has an impact on the treatment, ultimately. I heard you kind of do a little celebratory yes, cancer-free. Is this what I'm hearing across the table?
Yes.
Okay. So what's past that? How often will you two see each other?
The standard per NCCN guidelines, since we're a National Cancer Institute now, the guidelines are we see every 3 months for 2 years, and then we'll see every 6 months for 2 years, and then annually after that. CT scans about every 6 months to a year are thrown in there. Labs pretty frequently. Every time we see her, we'll get labs on her, draw CEA level. The new thing that we're looking at now is circulating tumor DNA, or the Signatera test. Her attending, Dr. Al-Rajabi, is a big proponent of that. And so that's looking for the actual genetic markers of the cancer in her blood. If they show up, then we get kind of worried. And so we follow all these things to make sure that the cancer stays gone. The vast majority of recurrences happen within 2 years. About 80% of all recurrences will show up within 2 years. Within 5 years, almost all of them would have shown up. And so once you reach that 5-year goal, you're pretty good.
You're pretty good. How far out?
It'll be 2 years in May.
All right. I like to hear that. How has the surgery changed your life? Your digestion, anything, and how you live, what you eat?
I mean, I think you don't lose your rectum and part of your colon and not have some changes. But they did prepare me for, as well as they could, that there would be changes. And, I'll be honest, it's been a learning process over the last 2 years. It is, I know people like to throw it around, but like a new normal for sure. Things do not, my anatomy's different, so things are not going to work the same, but it's, over the last 2 years, things have gotten better and more manageable, and I'm still taking care of my kids. I'm still doing all the things that I want to do. We just traveled recently, so you know, it is a change, but it's not a limiting change.
It's a cancer-free new normal.
Yeah.
And I think that we can live with that, right?
Yeah.
Let's, we got to talk about family history and people being predisposed to this. Explain about that and what this might mean for her children.
Well, you know, I don't know her history completely, but yeah, there are genetic syndromes, you know, things that you can inherit that can make you more predisposed. The interesting thing about hereditary syndromes is we haven't identified them all, you know. In other words, we know of some of them, you know, and if you fall into one of those genetic categories, then we can make, you know, pretty good predictions as to how high your risk is of getting cancer. But there are strong family histories where half the people in the family are getting, like, you know, colon, breast, or ovarian cancer and uterine cancer, but we haven't identified the genetic change. I think these days we say about 15% of all colorectal cancers are due to a genetic predisposition, or something like that, you know. So most of them are not. That's the interesting thing, is most people are like, I don't have a family history. How could this have happened to me? Well, the reason is because most of them are not genetic predisposition cancers, and you know, it's shocking to people when they hear that. People think you have to have a family history, but you don't.
You don't.
Yeah.
Let's get to some questions from our viewers this morning. And question is, are any of your family members hesitant, or are they eager to be screened?
I think for my family, it is a mix. I think in this case, I do have Lynch syndrome, which is a genetic you know, predisposition to certain types of cancer, colorectal cancer being one of them. And you know, my mom, or my parents both got tested, and it turns out that my mom was positive for Lynch. And then I have some family members that are, you know, that got tested right away, you know, while I was in treatment, got tested, and I have some family members that have still yet to be tested. So I think, you know, it just comes down to what people are, you know, what information they're willing to know and
act on.
Yes.
Once you have the information, it can be a scary time.
Yeah.
Paul wants to know what your thoughts are on at-home screening tests. Are there at-home
Probably
screening?
Cologuard is what we're
Cologuard,
talking about. Cologuard's approved, 80-90% sensitivity and specificity for finding adenomas or cancers. Very easy to do. If that's what somebody wants to do, I'll take it. I'll take anything I can get if somebody wants to screen. The trick is you got to accept that if it's positive, you're going to be right into a colonoscopy. And so you can make an argument for just going straight to the colonoscopy, because then if they see it, they take it out. Remembering that colonoscopies aren't there to diagnose cancers. They're there to find the polyps before they turn into cancer.
But it does not take the place of a colonoscopy once you reach that age of being able to get one.
Yeah, you can substitute it actually for screening. So a lot of people like it because then you don't have to do the prep for the colonoscopy and things like that.
Don't get me started on that.
I know.
Because you're the one who pushed me to get my colonoscopy, which I appreciate because I was 2 years late, but that you didn't quite get me in the know on the prep.
I usually say that when I'm leaving the room.
As you run down the hall,
yes.
I appreciate that.
But colonoscopies are easier to tolerate. I mean, people now who get colonoscopies don't realize back in the day the medications we had for these scopes weren't the same. I mean, you literally are knocked out, you don't remember any of it. The prep is tough, but even that's better than it used to be.
Yeah, it is.
So, yeah.
It is. Lifestyle factors. What lifestyle factors could increase your risk?
Well, I think you can only do so much. You know, obviously there are things we know that are high risk. You know, weight gain is one of them. You know, definitely don't smoke, don't drink too much, eat a healthy lifestyle. I think we know what that is. You know, exercise, but eating healthy comes down to, you know, limited carbs, high protein, low fat diet, lots of greens. You know, I mean, there's
Boo.
I know
It's
like
so
stuff
fun.
that doesn't taste great. Yeah, but you know, but the reality is we all know what a healthy diet
Yeah.
is. Yeah. So.
Yeah, just do, kind of the ABCs of good health. And question, Dr. Ashcraft, and you had mentioned it, Tiffany, last question is, can you see cancer on a colonoscopy when you look at it the day somebody gets a colonoscopy? You know what it is, or are you just suspicious of it?
You have our GI docs here, especially, and those that do a lot of colonoscopies, you know in your heart, but you hate to say the word because you want that tissue you want some pathologist to tell you, yes, this is what it is. And so you want to kind of prepare the patient for the worst, but wait for that pathology.
And then just lastly, Can X-rays be used for screening versus a colonoscopy? What's the difference, and what are they seeing that?
There are some tests you can do a CT colonography to help look for it, but they're not near. They're nowhere near as good.
Yeah.
We really focus on colonoscopies. We will take the stool studies at home. CT colonography is really reserved for patients that can't tolerate a colonoscopy.
Yeah.
All right, Dr. Alcaz.
And they can miss really a smaller cancer too. The CT colonographies.
So on that note, what's the big takeaway today?
I think the key is, again, be really well in tune with your body. When you recognize any of these symptoms, take them seriously. And I think it was really well stated that when you see your primary care doctor, there's nothing wrong with being proactive. I mean, sometimes, the primary care doctors have a really tough job, let's face it. I mean, like Dr. Ashcraft says, 9 out of 10 times it's not a cancer, so you can imagine it's hard to pick up that one, but I think as long as we know that patients with these symptoms when they're younger need to be tested to take it seriously, I think that'll go a long way. And younger patients knowing that they're not invincible, they can get cancer.
So know your body and be able to communicate that with your primary
physician. That's exactly it, yeah.
What's the takeaway, Ashcraft?
Much like you said, be an advocate for yourself. Yeah. Don't be afraid to talk about these things. We know they're going up in younger patients, so younger patients need to kind of have heightened alert. The primary care doctors need to be kind of heightened to that. But not only we talk about younger patients, but one thing we didn't hit on is racial disparities. African Americans, 20% more likely to be diagnosed with colon cancer and 40% more likely to die of it. Yeah. And that needs to be addressed as well.
Absolutely. Tiffany, again, thank you for sharing your story and just being a face of something nobody ever wants to be the face of. What's the biggest takeaway from your personal journey?
I mean, I'll reiterate what they say. I think it's huge to not only be able to communicate with your primary care doctor, but have a doctor that you feel comfortable talking with, and that may take changing doctors or finding someone that you do feel comfortable talking about, your digestion and your stool and blood and your poop. And, I mean, these are words that make people uncomfortable and made me uncomfortable until a few years ago. And so I think just having that comfort level with your doctor is important so that when you do notice changes that you're not waiting to say something or waiting until you feel like it's bad enough to bring it up. If it feels off, it probably is. It may not be cancer, but it could be something that they could fix or help you with if you bring it up. So.
Thank you for your words and your message today. Thanks to all of our guests and to our viewers for being with us. We'll see you back here tomorrow at 8. Genetic tests are changing healthcare, and doctors aren't the only experts who should read your results. I'm Jessica Lovell on the next Open Mics with Dr. Stites. We show you the science behind genetic counselors, how their niche expertise can help prevent misdiagnosis. Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.